Welcome to this podcast on identifying obstacles to staying at and returning to work, also known as blue and black flags. My name is Burton.
And mine is Kendall. The aim of this podcast is to provide line managers and workers with practical techniques to identify and manage obstacles to work. The main focus is musculoskeletal problems, although the approach is widely applicable to other common health problems and minor injuries. Obstacles to work can arise in three main areas: the person, their workplace, and the everyday context in which they function. The focus for this video podcast is the workplace and context, known as blue flags and black flags. This three-part podcast has three learning objectives. At the end of it, you should be able to describe the role of flags as obstacles to activity and work, outline how to identify flags as obstacles to staying at and returning to work, and describe strategies for facilitating return to work. The topics that we cover include issues affecting return to work, obstacles, definition of blue and black flags, something about the history of how they came about, their relevance, how to identify them in a workplace context, how to ask about blue and black flags, and how to manage them, and obstacles to staying active and working. We'd like to draw your attention to some very important source material on which this podcast is based. The most important of these is the definitive guide to identifying obstacles using the psychosocial flags framework, entitled Tackling Musculoskeletal Problems. There is also a very useful paper by Bill Shaw and others in the Journal of Occupational Rehabilitation on early screening and intervention. We'd also like to remind you of the very important report, Is Work Good for Your Health and Wellbeing? Published by Gordon Waddell and Burton, and also three other reports that you may find very useful. These are all freely accessible. One on vocational rehabilitation, what works for whom and when, the costs and benefits of active case management and rehabilitation for musculoskeletal disorders, and the management of upper limb disorders and the biopsychosocial model. From the outset, our interest is on improving health outcomes. And to achieve this, we need to ensure that we have our knowledge base, that we synthesize this, and we put it into action in order to achieve those better outcomes. Of course, what you think of as a health outcome depends on who you are and what your point of view is. Broadly though, they include the subjective reduction in symptoms, feeling better, the improvement of functional limitation, being able to do more, and regaining the ability to participate in work, either by staying at work or returning to work. Just remember that these are not equivalent and there's no straight line between them. Getting everybody to recognise that work is an important health outcome is an ongoing challenge. Even if we look at NICE guidance, what we'll discover is that participation and activity in work is actually rarely seen as a health outcome that they consider. In fact, only 25% of guidelines offer advice on rehabilitation, and only about 10% offer advice on return to work. There are signs of change, but there's a great deal more to be done yet. It's also important to remember that there's a hierarchy of work participation goals. For example, if we think about stay at work, generally that involves either the same job or a modified job, whereas return to work has more options. If you return to work with the same employer, you could do the same job, a modified job or different job, and if you go to a different workplace, a different employer, you may have a different environment and a different job. A very important principle of modern rehabilitation is the idea of helping people to work whilst they are recovering. It's very important to remember that there are a lot of benefits of being at work. And if we're not there, we lose these. These include things like a routine, a structure to the day, a lot of our social relationships, mental stimulus, self-esteem, activity, well-being, etc. And just a reminder that prolonged absence is a seriously bad idea for our health. We'd like to turn our attention now to the issue of epidemiology, which is to do with counting the numbers of things, and look at upper limb disorders as a very good example here. One of the things we know is that there's a high background prevalence of ULDs in the general population, not the people who are seeing healthcare practitioners. In fact, the 1 week prevalence is about 50% for upper limb and neck symptoms. It varies depending upon the region, where you live, population, case definition, etc. So in that regard, it's very similar to back pain. There's a higher prevalence of non-specific symptoms versus specific diagnoses, and frequently there's more than one region affected. Symptoms are usually recurrent, like many musculoskeletal or soft tissue symptoms, and it often leads to activity limitation, but most workers actually do remain at work. However, some go on to long-term incapacity, but it does mean that ULDs can be considered yet another type of common health problem. The epidemiology also tells us quite a lot about the relationship between health problems, injury, and symptoms. Of course, some jobs do contain hazards with elevated risks, but the question is, risk for what? Is it for symptoms? Is it for injuries? Is it for something more serious? We do know that most jobs entail normal type of activities that produce both fatigue and a sense of strain, but not major damage. We need to distinguish between the report or expression of symptoms, between symptom modulation, physical damage, and disability. When it comes to the deleterious consequences, the longer-term disability from musculoskeletal problems depend more on psychosocial factors than on what has happened. For this reason, we suggest that the term work-related is largely inaccurate and misleading when it comes to musculoskeletal problems because it implies a direct causative link that in fact is not there. The term work-relevant is more appropriate because the symptoms are relevant to work inasmuch that they recognise that it can be difficult to do normal work tasks in the face of symptoms such as upper limb disorders, irrespective of the cause. And finally, an important reminder that people experience pain in the course of everyday activity as well as work. This means that they face a predicament. What should we or they do about it, of course, is the question. Despite the reduction in the physical demands of work, musculoskeletal problems have not declined as expected and hoped for. Preventing accidents is of course different from preventing ill health. Prevention strategies can be very successful in making work safe, for example, preventing falls from heights, but only successful for ill health when there is a clear link between exposure and a disorder, e.g. asbestosis. Unless there is a clear exposure-response relationship for workplace physical stresses, the prevention of incidents itself is actually not feasible. In fact, while the earlier evidence about occupational factors was equivocal due to the high proportion of cross-sectional studies, over the last decade we've had more and more longitudinal studies published. Physical exposures are associated with musculoskeletal problems, such as upper limb disorders or back pain, but the effect sizes are very modest. The timeline is often unclear, and there's the issue of symptoms versus injury. So it can be true for non-specific and most instances of specific disorder. Little evidence is available for cumulative exposure to typical physical stresses as causes of most musculoskeletal problems. However, workplace psychosocial factors are consistently associated with symptoms and sickness absence. We do have good scientific evidence that work is generally good for physical and mental health and well-being. Being unemployed and having unnecessarily prolonged time off work or sickness absence are generally bad for physical and mental health and well-being. Getting work can reverse the adverse health effects of unemployment. These findings apply for healthy people of working age, for many disabled people, for most people with common health problems, and for Social Security recipients. The provisos that apply to these findings are that the beneficial health effects depend on the nature and quality of work. Good jobs are to do with things like pay, security, support, safety, etc. Across the UK, sickness absence is estimated to cost something like £100 billion per year, and this of course is due mainly to lost productivity. The leading causes of sickness absence are mental health problems, musculoskeletal problems, cardiac, pulmonary, etc. About 10% of those who are on sick leave account for more than 85% of the total costs. And a question that always arises is what percentage could, in fact, continue to be productive. Remember that clinical severity is not strongly related to work disability. In rheumatoid arthritis, a better clinical status is not the same thing as fewer sick leave episodes. The return to work rates in spinal cord injury are about 45% at 1 year, independent of the severity of the injury. In low back pain, there's a threefold international variation in work disability, which is driven as much by policy as it is by anything else. And in the common mental health conditions, severity appears to be largely unrelated to work status. Unfortunately, healthcare by itself is often ineffective in improving work outcomes. In fact, once acute musculoskeletal conditions have stabilised, more treatment is usually worse for sickness absence. This holds true for things like back pain across a variety of treatments: spinal fusion, discectomy, extended physiotherapy, pain clinics, etc. It also holds true in other conditions such as post-bypass cardiac rehabilitation and common mental health conditions. The question, of course, is why? To answer this, we feel that we should think about being off work as a separate type of condition, a separate problem. In fact, it is largely a psychosocial condition. There are a unique set of causes, associated factors, and effective treatments. It's distinct from the underlying medical condition that it is often attributed to. To consider this more fully, contrast the predictors of clinical and work outcomes. In problems like back pain, the predictors of symptoms include things like pain severity, the duration of the problem, whether the person has got a somatic focus, their ability to cope, and the history of the problem. Whereas predictors of work outcomes for back pain are things like whether there's conflict in the workplace, whether there's inflexibility at work, whether the person has fear of injury, a lack of autonomy, pain severity, or if they hold a catastrophic view and tend to catastrophize. To explain these differences, we need better theories about return to work. At least two are worth thinking about. One is return to work as a negotiated process, where the key interaction is between the worker and the employer, usually the line manager. External expertise is secondary, and it is based on communication. The adaptational model involves both worker and the workplace, others as well, focuses on processes where disability is more important than diagnosis. There's a focus on the initial return to work experience, and recurrent work disability is seen as maladaptation. In both cases, there is an early window of opportunity. A really important consequence of these new findings and these new theories is to understand that the policy workplaces have affects work outcomes. And fundamental to this is the early response by the line manager. There's an independent additive effect of negative line manager responses. The practical implication is that line managers should avoid being unsupportive, blaming towards workers, angry, or expressing disbelief, as these will develop worse outcomes. It's no great surprise then that there is an important role for training line managers about this. They need to know about things like making immediate contact, not blaming, how to ask questions, being positive and empathic, expressing an I want you back at work approach, having a safety focus, using problem-solving strategies, regular follow-up, providing accommodations in the workplace, updates and functional inquiry. These can easily be provided in effective training packages that involve about 2 2-hour sessions that are interactive, that are supported by senior management and are delivered during regular work hours. Providing an accommodating workplace is a key element for return to work across a range of health problems, including musculoskeletal ones. It's possible, for example, to have a 30% reduction in sickness absence with low back pain problems. Accommodation needs to be allied with therapy. It should be supportive and express a valued contribution. It's also time limited with periodic review. It uses adjustments and a transition back to full participation at work. It's usually self-arranged, but it can involve use of outside expertise when needed. All of this adds up to an approach that is biopsychosocial, that uses self-management as both a process and an outcome, that involves stepped care, using only what's needed when it's needed, that involves problem-solving, person-centred and solution-focused approaches, and is based on a principle adapted from Norton Handler that work should be comfortable when we are well and accommodating when we are ill or injured. Given that work is generally good for health and well-being, the imperative is to help people stay at or return to work. This means that people who want to work should have the help that they need. Remember, this is not the same as being made to work, though. So we need an integrated approach. Stay at work and return to work don't just happen. Action is needed. Remembering that healthcare alone is not enough. Vocational rehabilitation is not something to try after healthcare has finished or failed. The workplace must be involved from day one, and we need to encourage people to begin working whilst they are recovering. Let's continue our focus on injuries and common health problems. These are the less severe illnesses or injuries. They're responsible for about 70% of absence and long-term incapacity. As mentioned before, they involve the mild to moderate mental health problems, stress, musculoskeletal conditions, and cardiorespiratory conditions. There's a very high prevalence across the population, characterised more by symptoms than by disease or impairment. There's very often coexisting symptoms, such as physical and mental ones. There's an untidy pattern of symptoms of varying severity at irregular intervals over the life course. And healthcare seeking for about 10% of episodes occurs, while most episodes settle uneventfully. There's multifactorial causation. Work is usually only one contributory factor. Most people do remain at work or return to work quite quickly. Essentially, these are whole people with a manageable health problem. given appropriate support, opportunities and encouragement. Remember from our epidemiology that everybody at some stage has no symptoms. Nearly everybody at some time has some symptoms. Fewer people, much less of the time, have work-relevant symptoms, and even fewer go on to have healthcare or absence. Fewer again go on to extended absence or litigation. Let's use an example to illustrate pretty much all of what we've been talking about so far, and let's call this Andy's predicament, a little story. It all started when I woke up with severe back pain. The doc gave me tablets and told me to rest and stay off work, but I didn't get any better. I was sent for x-rays, which showed degeneration. Then I had to wait around to get treatment. The therapist said it was my job that caused it, so I shouldn't go back till I was fully fit. By that stage, I started to get really worried and feeling down. The family won't let me do anything, so I don't get out much. The people at work haven't been in touch, so I don't know what's happening about me getting back. People said I should put in a claim. The solicitor sent me to a specialist, so it must be serious. This whole ongoing saga has just taken over my life, and all I really wanted was a bit of help. What we want to do is to try and prevent this kind of slow slide to disaster. Part of the problem is that people change their role as they go along. Before they get symptoms and at the time when they start getting symptoms, they're just an ordinary person. As soon as they go and seek healthcare, though, their role turns into that of being a patient. If it goes on longer or persists, then they become a beneficiary. And if it fails to recover or to allow them to participate, then they end up, in a sense, becoming dispossessed. Remember that when we're talking about why some people slide to this long-term disability, that they do not have a more serious health condition or more severe injury. It's not about what has happened to them, rather it's about why they don't recover. And we need to think here about them facing obstacles to recovery and participation. Our focus is going to be on two types of obstacles. Those that are like hurdles in a way that we can overcome, and those that are like things that are blocking the road that we need to navigate our way around.